received her medical training, excuse me, I'm sorry, received her medical training at Howard University and completed her physical medicine residency at the University of Pennsylvania. She also completed acupuncture training at the Helms Acupuncture Institute at the University of California in Los Angeles. Wow. Your clinical interests include treatment of neck and back pain, overuse injuries, carpal tunnel syndrome. I know a lot of folks who can help. Degenerative joint disease of the spine and extremities, muscle pain, bursitis. In addition, Dr. Peters performs nerve conduction and studies to diagnose neuromuscular diseases. She's a resident of Prince George's County. Ladies and gentlemen, give her a hand. Our new commissioner. Doctor, do you have anything to say to us? Okay, thank you very much. The first item, of course, is the approval of the minutes, the historical record of this institution. So included in your packets are copies of the minutes from the July 20th public meeting of the commission. If you don't have any changes or corrections, if you haven't seen anything that is inaccurate or inappropriate, I'll entertain a motion for approval. So we'll have a motion to approve the minutes. Commissioner? Second. Thank you very much. Any discussion at all? Okay. All in favor, say aye. Anybody opposed? Good. All right. Commissioners, you've all received your written updates from the centers. You've all had an opportunity to read them. Do any of you have any questions on the updates at all? Anybody? No questions. Okay. Ben, do you have anything to add, or any of the center directors?
Thank you, Mr. Chairman. There are a few things I want to highlight today. First off, as you know, we've been working with our rural health delivery work group for about a year. The final meeting will be held on September 28th in Annapolis. At that meeting, the work group will consider recommendations that have been developed over the course of the summer, as well as the study team from University of Maryland and the NORC Walsh Center on Rural Health. If those recommendations are approved, and we expect they will be in one form or another, those recommendations would come forward to the MHCC at the October 19th meeting, where you would be asked to act on the recommendations and the report, after which that report would be submitted to the legislature. We expect that there will be legislation coming out of this work group. I can't say specifically on how it's going to evolve, whether the governor's office, legislative leadership will take a role, hopefully, to ensure passage. Likely will require collaboration, but we expect some immediate statutory changes to be made as a result of the recommendation. Secondly, also on October 19th, the commission at an 11 o'clock news conference will unroll our price transparency tool. This is a effort that's been dear to the hearts of many of the commissioners, and the effort will look at 4 shoppable episodes of care, bundles of care, if you will: hip and knee replacement, hysterectomies, and vaginal birth. The work has been going on over the last several months. As you know, we've talked about this since the middle of the summer. We've added additional data, and we think that this report is going to generate some significant state as well as potentially national attention. We are mindful of the need to keep hospitals and other providers informed. It's been characterized that we'll be holding a boot camp for hospitals in the near future to run through all of their results, provide an overview of the methodology, and be available to answer questions I hesitate to call it a boot camp, but maybe training would be better. But I think this is very important as we move to greater transparency to make sure that the subjects of these efforts are aware of the results, are confident that we are fair and are rigorous in our approaches, and they have an opportunity before the information is publicized to voice any concerns they may have. Next, in terms of our efforts and work with partners, not in the update, but evolving actions, the Commission has agreed to share our all-payer claim database with the Maryland Health Benefit Exchange. The Maryland Health Insurance Coverage Commission, a new commission that was formed in the past session of the legislature to look at ways in which Maryland's healthcare reform could be enhanced and preserved as changes take place at the national level, has asked the Health Benefit Exchange to re-examine the reinsurance program that existed in Maryland between 2014 and 2016. That reinsurance program provided some additional protections for carriers that had significant high volume, high expense claims, provided for the reinsurance pool to fund those additional costs, and consequently was a factor in keeping premiums lower than they might otherwise be. We expect our all-payer claim database will be used for that same purpose. We also think it's likely that it will also be used by the exchange as they examine one option that exists under the ACA, the so-called 1332 waivers, which allow states additional flexibility within the confines of the ACA to provide for and align their insurance market to more consistently deliver care with what the state conceives as appropriate aims. There are numerous constraints along the 1332 waivers. 7 states have already sought or in the process of seeking approval. What I would say is that if you look across those waivers, they really span quite a range of efforts and initiatives, and I would expect that that what Maryland would consider, particularly as it relates to reinsurance, would be something that the federal government might want to consider. Lastly, just one note, in your materials today, you will see a new summary on the status of the total cost of care model. We're not planning a formal discussion of what's called the second phase of the all-payer model, started in 2014. As you know, in 2019, the state will be required to migrate to a new model. That model is called the total cost of care. It will focus not simply on the hospital setting, which has been the focus of rate setting for more than 40 years. I guess we've done enough of that, and the idea is to expand the model to cover other delivery sites and other providers. This is not to say that they're contemplating or we're contemplating rate setting, but they will. The model will engage other providers in much more voluntary and flexible ways, I think, moving forward. The one area that we will be working on, and we'll be hearing a glimpse of that today, is on the primary care efforts and our efforts to expand a new model of advanced primary care to a broad swath of providers in the state. It's important to remember some of the constraints and there will be major challenges with the new model that will roll in 2019. One area of debate has been on the level of cumulative savings that would be achieved by 2023, the $330 million that the state has committed initially generated significant concern among hospitals. It's my understanding that as a result of ongoing negotiations with our colleagues across the way, that hospitals are somewhat more confident that these ambitious goals could be met. It's important to emphasize that $330 million in additional savings, cumulative savings, would be coming from both Part A, the hospital side, and Part B, the non-hospital. Typically, we think of that as the physician and other provider side spending. So these other types of models, and they're not going to be done on a mandatory basis, but rather voluntary, are going to be key to the success of the model and the key to improving the care of the quality of care here in the state. Lastly, a couple notes. Linda and her team presented on spending for the privately insured in July. That report is now on the web. I encourage you to take a look at it. If you haven't seen it, we're going to be accelerating our development of the 2016 report and hope to have it to you earlier than the 2015. And also our ambulatory surgery report based on the 2016 survey year is now available on our website. I know that stakeholders are curious about the inventory of AMSURG centers in the state, and the most recent data we have available is now accessible.
Okay. Thank you very much, Ben. Commissioners, are there any questions for Ben? No? Okay. Okay, we're going to have a presentation on the, oh, wait a minute, no. Yes, I almost forgot. Tourette's, thank you. Yes.
Okay. Good afternoon, Mr. Chairman, Commissioners.
Floor is yours, Tourette's.
Thank you. I'm very pleased to introduce our newest member of the Center for Quality Measurement and Reporting team, Sebastiana, or Tiana Gianci. She's right here. Tiana will lead the development of an outpatient provider quality initiative, focusing initially on hospital outpatient services, then expanding to other outpatient non-hospital settings. Sebastiana has a wealth of experience in quality improvement and patient safety. Prior to coming to the Commission, Tiana worked on international health issues as an independent public health consultant. She also worked with the Agency for Healthcare Research and Quality as the lead writer on the Patient Safety Chart Book and the National Healthcare Quality and Disparities Report. She has worked with the World Health Organization on healthcare-associated infection issues, and she has worked on international health issues while at the World Bank and UNICEF. Tiana holds a master's degree in international development with an area of public health from Johns Hopkins University and is currently a PhD candidate in the School of Public Health at Morgan State University. So I'd like to ask you to join me in welcoming Tiana to the team. Thank you.
You're welcome. Any other commissioners? Any other directors? Okay. All right. Now we will have a presentation on the Practice Transformation Network. This is a progress report. The presenters will be Niharika, I hope I pronounced that correctly, Niharika Khanna, is that correct? And Associate Professor of Family and Community Medicine at the University of Maryland School of Medicine, Susan D'Antoni, who is the CEO of Montgomery County Medical Society, will present on the performance of the Practice Transformation Network here in Maryland. The Commission is in partnership with the Maryland State Medical Society and the Maryland Learning Collaborative, and they're a subcontractor of the New Jersey Innovation Institute, which is a recipient of the grant for this project from the Centers for Medicare and Medicaid Services. So joining them at the table is Melanie Cavaliere, Chief of Innovative Care Delivery. Welcome very much. We're happy to hear you, and let us hear about Practice Transformation.
Good afternoon. I'm just going to do a brief introduction. Thank you, Mr. Chair and Commissioners, for letting us present today. It's our pleasure to be here to show the progress of the PTN. We are making considerable success to achieving the milestones and goals established by CMS. So feel free to ask questions throughout the presentation, or if you'd like to hold them to the end of our presentation. And I'm going to now turn it over to Dr. Khanna to go through the slides.
Thank you all for inviting us. Thank you, Mr. Chair, and all of the commissioners. Thank you to the MSCC and especially to Melanie. We're very pleased to share with you our progress on developing a practice transformation network in Maryland. This has included primary care and specialty practices, so both have been included in that. I have some fairly dense slides, which some of which I'd invite you to take a look at. And it will walk you through what practice transformation is for the CMS in the Practice Transformation Network. As you all know, the practice transformation has taken on a sort of a multitude of meanings. It depends on who's recognizing you and which agency you're reporting to. But in the Centers for Medicare and Medicaid, this is the definition that they've utilized, which is to create a more efficient and effective system, enhance quality, and prepare clinicians and those in the community in particular to be ready for future models, in particular the MACRA, which is the most immediate model that's upcoming. We're also recognizing that a successful practice in the PTN, as defined by the CMS, is a practice that has committed leadership. It utilizes a team structure, and the operational culture is one of collaboration in decision making and in moving the practice forward. There is a fair amount of practice redesign that we're working them through, and leading essentially to population health, which is to manage a panel of patients that belongs to that particular practice. We're also trying to share with our practices those business strategies that CMS would like and some that are specific to Maryland. Next slide. So the TCPI, which is the Transforming Clinical Practice Initiative, which is the umbrella initiative under which Practice Transformation Networks function, is one of the largest investments that CMS has made to support clinical practices nationwide. And there are about 27 total practice transformation networks that are funded under this Transforming Clinical Practice initiative. And as part of this particular initiative, there's about $685 million that have been invested in just putting together the infrastructure to move clinicians towards the new models of care. And the idea is to generate savings with reduction in utilization of practices, basically trying to enhance the care of patients and reduce utilization primarily in hospitalizations and in ED use. So the TCPI was developed by the CMS to align with the Affordable Care Act and essentially enhance health outcomes for millions and millions of patients who are going to be included under this. And they estimate about 5 million patients come under the total network, the TCPI initiative. And the goal, again, is to create the evidence to say that practice transformation truly is essential to the Affordable Care Act. And so we are sort of in not quite a demo program, but more like a initiative under which we hope to accumulate real life data, which will ultimately sort of justify or create a rationale for why practice transformation is essential. Under the TCPI, there are no incentives for practices, but we know that in the future, as they get into MACRA, MIPS, and others, that there are going to be some financial benefits that a practice may avail of. So a practice transformation network under the Transforming Clinical Practices Initiative is essentially a peer learning opportunity. You may know that the Maryland Learning Collaborative was put together with state, community, and university partnership, and that's who I represent today. And we have run a learning collaborative under the prior MMPP and now under this initiative, which is the Practice Transformation Network. And what we're trying to achieve is peer leaders in the community who will develop the processes that become best practice locally and share with their peers in the community. Every practice in the program is expected to have an active role in transformation. So although we do have very efficient and very good coaches that are sent out into the practice, but the practice itself is required to actively transform themselves and then to follow the guidance that the coach provides to participate in the learning opportunities that we create, and then to ensure collaboration with others in their own individual communities. So looking at the overview of what they provide, I also want to just make sure that you recognize that these are practices that are volunteering to participate in this program versus going to an ECO or other places where they think there may be remuneration. And they're coming to us for multiple reasons, but one of the reasons is because they want to be ready for BACRA. Each of these practices is required to have an electronic health record and to allow a coach into their practice. That is absolutely essential. And to engage with that coach in a meaningful manner. We'd like for them to start at wherever they are. We want to meet them where they are, and then to walk them through the steps of transformation as they're defined by CMS. And those steps are essentially called phases under the CMS PTN model. And we will take a practice where they are and then essentially walk them through the 5 phases to lead them to a place where we can graduate them. And we hope that each of these practices will graduate into an advanced payment model or even more advanced one in the future. Practices are required to report quality metrics to us, and those metrics have been determined by the NJII, which is our parent organization. So the Maryland Practice Transformation Network is a sub-grantee of the New Jersey Institute of Innovation, who received the $50 million grant. I think that might be the next slide. That's the next one. No. We'll follow the slide. Okay. Next one. Thank you. So our objectives are essentially, as outlined in that slide over there, to get practices over to a place where they are comfortable participating in an ACO and they're able to succeed there, so that they are not only able to manage their patients better, but they can also provide better quality care, they can reduce costs, and be in a position to share in any sort of cost savings that exist in the model that they participate in. Next one. Okay, so our approach is to assess the practice. We do a baseline assessment of every practice that agrees to participate with us. It's a very deliberate process, so we give them a consent form of sorts, which is a participation agreement, and they will review that with their entire practice and then determine whether this is a good fit for them. And then they come forward and become our participating practices. And then we then start this assessment process, for which we use a very structured intake tool, which again is CMS developed. And it is called a practice assessment tool, and also has capability to use that same document as a living document to walk that practice upward through the phases of transformation. We are collecting some information from electronic health records, and we are hearing from practices that the electronic health record is extremely unfriendly to some of the processes that are being demanded under the new MACRA, that it is very difficult for an average practice to start to extract metrics and then to record information in the right places where we can actually pull them to demonstrate that they are making improvements. But every practice has been working at it, and every practice is trying to engage with the vendor that has provided that EHR to them with spotty success. Some vendors have come forward to help them, but a lot of them haven't. So that has been one of our major issues that they faced. We are looking at using what's called the change package. So after you do the assessment using the practice assessment tool, the CMS would like every practice coach to use this thing called the change package to extract from that evidence-based strategies, which will help this practice move to the next phase. And that has been very, very interesting to observe how that rolls out into different practice settings. And then we measure them. We do try to measure them based on fixed KPIs, but as we are realizing in specialty practices that you really can't fit a specialty practice into a primary care mold and use the same KPIs. So we're having some challenges there. We're still working on a sort of a more structured way to provide feedback to CMS to share our experiences on the road, and also hopefully make the programs that come out in the future be more friendly to specialties. So these are the phases of practice transformation.
And what you're looking at is phase 1 up there, which is setting aims and looking at their basic capabilities. 2 is whether they're able to report and generate data, because we want them to be generating some data for us around reporting on these metrics. And the 3rd, which is outlined in red for you, is where we are right now. We are at trying to achieve some of these goals of lower cost, better care, and better health. And we hope to then move our practices forward into 4 and 5, which I outlined there for you. But right now we are close to 100, we aren't quite 100%, but we're in the 90s for achieving phase 3, and we will be showing you some results later on. Next slide. Okay, so this is where we describe our partnership with the New Jersey Innovations Institute. So the New Jersey Innovations Institute originally got a $50 million grant from CMS to implement the PTN. And they had at the time told them that they would have 11,500 or some practitioners. And then I think reality sort of set in and they realized that they could do about 9,000. So their budget was somewhat limited. So we are in Maryland, we were assigned 700 of those eligible practitioners, which we have now exceeded because there has been quite a groundswell of people wanting to join us. Our budget was $750K when we started, and we're probably going to have a similar budget this year as well. But our number of practitioners, like we said, have gone up with the amazing partnership we've had with MedChi and with MHCC in being our really fabulous working partners. Next slide. So the roles of the partners are outlined over there for you. The Maryland Learning Collaborative is MLC in short form. That's us at university. And we do partner with a number of people in the community because we realize that the universities, although they may have the, some capital around knowledge and such, but really to implement programs in the community, you need to have good partnerships to really do that. And we have had, over the last many years, several wonderful partnerships that have helped us with a number of things that you see on there. I want to recognize our Discern Health for the quality improvement work that they're doing with us now. We really, really appreciate them. And also a state-designated MSO that is ZaneNet that has helped us with coach retention and recruitment. At the university, again, we get to be somewhat strapped in how quickly we can move when it comes to recruitment and engaging people in the community who can work in the community. And so this has been a really wonderful partnership. MedChi, who will be speaking in just a second, have been our provider recruitment partners, and they have been just amazing. We are moving forward, going to be working with them on several educational efforts that we will do to target some of our participants. And that will be, I think, a really good partnership as well. Last but not the least, the MHCC has been the reason that we are doing this project, and that the partnership that we've had with MHCC at many different levels has been really invaluable. So I'm going to hand the mic over to Susan D'Antoni, who's going to share with us some aspects of their work.
Good afternoon, Mr. Chair and Commissioners. It's a pleasure to be with you today. I'm Susan D'Antoni, the CEO of Montgomery County Medical Society, which is the largest and most active chartered component of the Maryland State Medical Society. MedChi is pleased to be a recruitment and outreach partner in the Practice Transformation Network initiative. Resources provided through participation in the PTN, which have come at no direct cost to the physician practice, to assist physicians of all specialties and modes of practice to comply with this paradigm shift in Medicare payment methodology are welcomed and valued. Physicians, especially in smaller practices, have not only the challenge of running successful businesses, but they have the continual challenges of complying with various regulations which are put upon them, which do not usually come with any additional payment or funding for compliance, also known as unfunded mandates. It is certainly appreciated by all physicians that CMS would appropriate these resources to assist physicians to comply with the most recent and most significant of regulatory changes since the implementation of Medicare in the mid-60s and the advent of managed care in the early to mid-80s. Early on, MedChi recognized Montgomery County Medical Society's outreach effectiveness and asked MCMS to be the point organization for recruiting physicians statewide to participate in the PTN. We have used numerous outreach strategies to encourage participation in the PTN, including but not limited to targeted communications to practices of particular sizes, specialties, and locations. We have used in-person exhibit and presentation opportunities and targeted emails and faxes, and embedded copy and non-paid advertisements in specialty publications and in MedChi and Component Society e-news to communicate with Maryland's physicians and practice staff about the opportunity to benefit directly from PTN participation. We have held outreach educational sessions in areas throughout the state during which we discussed MACRA and the Quality Payment Program to enhance the awareness of physicians and their practice staff to the impending changes, and embedded information about the PTN into those presentations to let them know what they could benefit from in terms of the coaching services offered by the PTN. These services were customized to their needs. It was as little or as much as those practices needed to be able to successfully accomplish this transition to an alternative payment model. We have dedicated staff at Montgomery County Medical Society and MedChi to recognize and refer practices to the Practice Transformation Network, which we knew would be particularly challenged by this transition to the QPP, usually the smaller practices. This and other initiatives we can implement to help support independent private practice in our state is and will be good for all of us as patients in the future. Once a practice expressed interest in participation in the PTN, our staff, after vetting the practice for their current participation in an ACO or other advanced payment model and their use of EMR, would connect the practice leaders with Melanie Cavalier at the MHCC, and if needed with Dr. Khanna, to respond to any questions about participation and to make the onboarding process more effective. This afternoon and evening, we have 75 physicians and practice staff participating in both in-person and webinar streaming to educate them about MACRA. Many of them are PTN participants. The evening program also offers CME credits, which is an added bonus. To date, through these various efforts, we have recruited 185 healthcare clinicians, most of whom are physicians, to participate in the PTN. That's 185 healthcare clinicians in our state who are more prepared to transition effectively to the Quality Payment Program due to the resources committed to support medical practices throughout the United States. We look forward to continuing to partner with MHCC and the University of Maryland in this and other initiatives in the future. Thank you.
Thank you, Susan. Another partner that we should mention is MAC-HC. So the Mid-Atlantic Centers that oversees the FQHCs in our state, they have also been really wonderful partners. So we've had a number of fabulous people. And as you know, you can't move things in the state unless you have good partners. So I want to give you a little sense of what our progress has been to date. And we have right now 802 physicians, and they're about 90. I think that number is a little off because we read the numbers. It seems like there are 51 primary care practices and 53 specialty practices to date. But that number, like I said, is a moving target because we keep getting people who want to join us. And so it has constantly changed. We have now oriented practices to our services and to programmatic requirements. And I think through word of mouth, we've been getting more and more people, which has been very rewarding. We are seeing some movement in patient and family engagement, which has been a particular focus of ours. We have also been working on team-based care delivery. We've also worked on something that I'll share with you, I think it's on the last slide, on what to do with patients who have behavioral diagnoses in addition to
chronic disease, and that is probably going to be a separate sub-project for us because it's so huge we can't just roll it into what we're doing. We have worked with practices on PQRS for 2016 and supported them in meaningful use reporting in 2016. And this year we know that thankfully we don't have to do that. Next slide. So this particular slide, just to orient you, on the left is the milestones. What you see is number 9, number 11. Those are our milestones, which are part of the practice transformation process. And on the right, you see the state of Maryland, which is blue. Then you see New Jersey, and PR is Puerto Rico. So those are the 3 states that are in our under the NJII model, which is the New Jersey Innovations Institute. And we thought it would be interesting for you all to see that how far ahead we are of our peers. And so we have continued to be ahead. These are the primary care practices that are at phase 2 to 3. And as you can see, we are very close to goal. We hope to move them on to be 100% at phase 3 very soon. And we're particularly proud of number 19 and number 20, which is the quality improvement, teaching practices how to utilize QI methodology, how to train their staff members in quality improvement. So we think we've done a really good job there. Next slide. This slide is performance assessment for specialists. And again, here you can see on the left are the phase, the milestones, which are outlined over there for you. And on the right, you see Maryland in blue, and then New Jersey, and then Puerto Rico. And again, you will see that we are very much ahead of our peers, and I believe that is nationally so. So, except I don't have the data, unfortunately, to show you. I'd love to, but these are our data that we have access to. Next slide. Yeah.
Can I interrupt you on that previous slide? So some of those milestones seem to be negative milestones. So number 1, practice monitors metrics, no improvement yet, and we're ahead of the other. Am I reading this? This doesn't look good.
Right. No.
Now,
Let me explain it to you.
Let's go back. Okay.
Right. This one.
Here we are. So
right.
Identifies high risk, but other.
So I think when you the previous one, Fran's talking about this one. Yeah.
Yeah, there we are.
Keep that. Yeah.
You see what I'm
so,
at 97%.
Right. So what you're seeing is now when you cut and paste these milestones from the baseline, when you start at phase 1, that's what we estimate that the practice monitors metrics, but there's no improvement yet. Now remember that metrics improvement is going to be kind of a step up. First, you got to learn how to collect the metrics, how to recognize what's the metric. Then you start collecting them. Then you start tracking your progress over a variety of quarters. So the way CMS has written this, although it looks like a negative, it's not
like
intended to be one.
Ahead of us,
no,
right?
No, they aren't.
Okay.
They're way behind.
Okay.
So it reads the other way, but you're right. It's written kind of weird. But when you read the explanation of this metric, it basically says to you that they're monitoring metrics. All they want in milestone 1, that's milestone 1 up there, is that they're able to pull out a blood pressure metric and that they can see it. Because remember, our practices are starting at a point where they have never seen a metric. So when we start to work with them,
I just think this is the way this is presented.
Yeah,
is that confusing?
It's confusing. We'll take the second pieces off because we're not giving you the explanation to it. Yeah. Thank you. Okay, so in this particular slide, I think this is sort of a composite to show you where we were at baseline, which is the second column, and where we are currently, which is average current score, and the average change, which you can see by state. So if you go down Maryland, Jersey, and Puerto Rico, you can see the rate of change. And then on the right, where there's a line, it just basically tells you how these practices have, whether they've increased their scores, they've decreased their scores, or there has been no change in their scores. And here you can see that Maryland has had almost 100% increase in scores. Jersey is actually pretty close behind in this particular side. And Puerto Rico has a ways to go. And I think they've been hit by the most recent storm, and so there have been further delays there. But we volunteered to go to San Juan at any point to show them the way. Next slide. So this particular one is not something that we're terribly proud of, but we thought it was important. You see our key performance indicators, and we want you to know that we had a huge influx of practices in that last quarter of 2016. And so that's when we really started to see practices just rolling into the program, which you can see demonstrated. So if you follow with me, the first one is the care plan writing for practices. We're pretty much at 100% on that now. But the next one is colorectal cancer screening. So we were starting at 16% in quarter one in 2016, and we were able to get our practices up to 47, 46% in quarter 2 and 3. And then we had this huge influx, and so we're back down to where we were, where we started. So we have a challenge for us to get the new practices to perform at where the older ones were. Yeah, so the way we're capturing colorectal cancer screening is the recommendation by the NQF, which is done screening, not recommendation. So we're basically using mostly NQF and some CMS metrics. All of these are under the ACO model, and these are actually done. So, for example, I didn't bring any of the other ones, which you could have a similar question, but in colorectal cancer in particular, unless you document done in a particular spot, you can't pull it out. So that's part of what we do, is to show practices that not only have you done the work, but you have to show it. So in order to show that, you have to document in the right place. So that has been part of what we have been doing. Next slide. Okay, so at program completion, all of our practices should be able to feel comfortable in moving forward into one of the new advanced payment models that are going to become available, we hope, very soon. Some are already available under ACOs and others. We think that all of them will be much more receptive to coaching, peer learning. They already are, and that they will be able to do patient-centered care in a more efficient manner. Next slide. And some of the initiatives that I wanted to mention before we close is that we are looking at assessments with practices every 6 months, which we do anyway. And we also measure the key performance indicators quarterly. That is a part of our program. That's sort of the structure of the program. But we have been educating them on what MACRA is, what your options are under MACRA, why you should join an AAPM, and why you should join an advanced alternative payment model, and how much additional revenues you could make under that if you were a well-functioning, well-oiled machine. We are exploring the behavioral health and opioid management program as sort of an overlay on what we do, because we started to realize that we want to do multiple things. And under that program, we want to look at expanding capacity of primary care practices. We're looking at utilizing our hotline for practices that they can call and say, I have a tough patient. How do I manage this patient? I've maxed out on antidepressants. What do I do? We're also trying to look at opioid management, starting with signing opioid agreements. So we're looking at rolling in a pharmacist, a psychiatrist, a social worker, the hotline folks into this model. Then ultimately looking at what our metrics going to be, what are we going to measure, is there a return on investment in doing this model? So we hope that this will be separately funded from what we're doing, and we can bring in these good people. We're working with our existing resource, which is CRIS. Working with CRIS, we're trying to work with them on multiple arenas. We want to look at utilization in particular. So we've asked for CRIS to work with us, and they have been very forthcoming in looking at how integrated our practices are into CRIS. So we're hoping that we can move them through tier 1, 2, 3, and then ultimately get them to Caliper, which is the model that CRIS has for extraction of metrics automatically from the EHRs. And that will reduce the burdens on practices, I think, moving forward, so that once it gets going. I have not yet seen Caliper work, but we're promised that it will work. And we do have a couple of practices at tier 3 now, and we hope the rest of them will follow. We are also asking Chris to develop a practice panel for us. So all our patients are under a single panel so we can track costs and utilization at a programmatic level as well. So that is in development. And through that, we hope to capture some opioid metrics, specifically one, suicide, and then two, also looking at opioid or other overdoses that happen under our patient structure. So all those things are under development, and we certainly hope to come back and share that with you in the future.
Okay, thank you very much, Doctor. Are there any questions for the panel? Anyone? I have one. You're undertaking quite an ambitious effort here, and I'm happy to hear that you seem to have a great deal of enthusiasm, more than perhaps you expected. People are actually signing up for this, and all of the metrics that almost all of the metrics you're dealing with, except for the last set of performance indicators, are focused on the performance of practices in meeting the practice standards that you set. My question is this: talking about future initiatives, are you planning to do an analysis or evaluation of the performance of this group compared to, let's say, a control group, people who are not in it, in terms of medical outcomes for patients? In other words, are people actually getting better? In other words, is the quality of their lives improved as a result of these medical interventions by this medical practice initiative? Are you planning anything like that?
The short answer would be no, but so to just put a caveat on that, under the MMPP, we did have a structure like that where we had a control set of practices that we had utilized. And we've just submitted the first paper from that where we've looked at outcomes that the patients had. And I think it has really been an eye-opener for all of us who were participating in the development of that document. I do believe that we should look at outcomes that are patient-centric and not just quality metrics. You know, sometimes quality metrics are misleading at times. A lot of them are about documentation and, things like, well, we learned this yesterday. But really, it's about the patient. So if we want to look at patient outcomes, and as we move forward, we want to look at what are the chronic disease outcomes, the utilization of the drugs, for example, not meaning drugs as a medicine, and then also ultimately looking at how often they go to the ED. The utilization of ED tends to be the most sensitive metric of transformation, and ultimately down the road you start to see reduction in hospitalization and others. But so we'd love to do that. In fact, if I could indulge your interest for a second, I'd like to say that now we have practices in our program that truly need help. These are not practices that we had in the MMPP who were really the top tier practices. These are the practices in this program that we've recruited from folks that are not looked at in any model whatsoever. These are the folks who are solos, two practices, with all Medicaid. Nobody wants to look at these practices. Nobody wants to help them either. So I believe this is a really wonderful group to see what the impact of transformation is. Under the MMPP, and I keep referencing that because I ran the MLC for that, but under that we learned that quality can be improved regardless of disease burden. That's what we had learned in that program. And I think in this too, this will come out if we go in and look at it. So it would be an important task, I think. Again, it would probably need to be funded in some fashion, but looking at an evaluation would be incredibly valuable.
Well, the reason I bring it up is because the federal government spends lots and lots of money on grants and various other sorts of programs. But, at the end of the day, it is what have you actually accomplished in terms of actually improving patient care. And what I mean, of course, is that the patient actually has gotten better as a result of the medical interventions of the medical practices. Rearranging the different ways of doing things, may very well be the height of efficiency on one level.
Mhm.
But at the end of the day, I think public policy makers, those of us who are in the business of actually making public policy, want to know exactly how it ultimately turned out
Mhm.
for the very object of this entire enterprise, which is the patient.
Mhm.
So, thank you very much for your answers. Any further questions? Commissioner Pollack.
Yeah, obviously. So I want to get to a point that you made sort of in the last comments here, and that is the focus on some of the provider groups who are going to be most challenged by making this type of transformation to single practices, two physicians, multiple Medicaid patients. And it seems like you're preparing them for several things. You're preparing them for delivering higher quality care, but really preparing them for better ability to report under MIPS, under MACRA MIPS, and to become eligible for advanced alternative payment models, which is really the drive, is to move people towards the AAPM. It's a much simpler model. It makes a lot more sense. And MIPS, I don't think anybody can figure out how MIPS is ever going to work for anybody. But I worry in those models, we're going to drive these 1 and 2 physician practices towards AAPM, and the deck is stacked against them in a lot of ways that you can't fix with just a practice transformation network school, even through 5 phases of it. And we're going to drive some of them out of business because they're going to move into AAPMs and be put at risk. So to what extent are we going to engage in like a 3 to 5 year model of tracking these practices, seeing how often they did move to AAPM and how well they did under that model? Because if they all just move to MIPS and do average under MIPS, it's really no long-term outcome there.
Yeah, so that's a very provocative thought. I think the way the CMS has structured TCPI as of now, there's no process for tracking practices that participate. However, they are welcome to ideas, so this may be something that we move forward. And I will generally share with you that these onesies and twosies are thinking of ways to coalesce so that they become more efficient, because with the larger practice, it's easier to hire a care manager, for example, a social worker or someone like that. Whereas if you're a onesie and a twosie, it becomes really difficult. So I think one of the things these kinds of models have done for these onesie, twosie practices is to put them closer in touch with other peers who have sometimes shared a coach, sometimes they share an EHR, and those are the sort of platforms under which they're able to establish some kind of collaboration, which allows them to essentially access the kinds of services which will ultimately be necessary for future models. And as you, I'm sure, are much more aware than I am, is that under the future model that's envisioned for the state of Maryland, there will be some supports in the community. And one of the things we hope to do as a PTN is to encourage practices to participate in those supports, because I think those are the ways that they're going to succeed.
Any further questions? Well, thank you very much, ladies. This has been terrific. Thank you very much. Our next item on the agenda is a request for a certificate of need for Future Care. Homewood, Future Care Homewood has applied for a certificate of need to relocate 30 comprehensive care facility beds that were temporarily delicensed at Good Samaritan Hospital. And they're renovating the existing Homewood facility. Mr. Kevin McDonald, who's the Chief Certificate of Need, is going to present the staff recommendation. Kevin, the floor is yours.
Thank you, Mr. Chairman, and good afternoon, Commissioners. This project would add 30 beds to a 148-bed facility on North Charles Street in Baltimore City. The facility was originally built in 3 phases dating back to the 1890s. It was acquired by the present owners in the mid-90s. The real estate and bed rights are owned by Future Care Homewood Properties, LLC, which has an ownership interest in 14 other nursing facilities in Anne Arundel, Baltimore, and Prince George's counties, as well as in Baltimore City. The facility's occupancy has been solid. Adjusting for beds that were closed for renovation a couple of years ago, it has averaged 90.2% over the last 2 years. The facility meets or exceeds the state average on 9 key quality measures and ranks lower on 5. The proposed project would renovate much of the facility and expand its capacity to establish a short-stay rehabilitation unit for cardiac and orthopedic patients. They would do this by purchasing 30 temporarily delicensed beds from MedStar Good Samaritan and renovate about 21,600 square feet of what is currently commercial space on the second floor of the facility. Total project cost is about $6.8 million, and it will be funded through a mortgage loan. The applicant listed its cost of CON preparation to be $25,000 each in legal and non-legal consulting fees. Key considerations that we look at vis-a-vis our standards and criteria. Quality ranked at higher than the state average on 9 key indicators and was lower on 5. Looking at need, there's no net need in the jurisdiction. In fact, there's an excess of about 200 beds. But this facility would not be expanding capacity in the jurisdiction in terms of it's acquiring temporary beds that are already in the inventory. Having said that, use of beds that are in the inventory is not really a free pass for applicants. They must still prove a need for the beds in the new location. And looking at that metric, the applicant's occupancy, again, has been solid, as was the occupancy of MedStar before temporarily delicensing those beds, both of them over 90%. Baltimore City's nursing home occupancy rate exceeds the state average for the last couple of years at about 91% during those 2 years compared to 89% statewide. Historically, MHCC practice has been to allow facilities with 90% or higher occupancy that meet other standards and criteria to relocate beds in the inventory by purchasing these temporarily delicensed beds from elsewhere in the jurisdiction. This approach has allowed the market to relocate beds within the jurisdiction from a facility that perhaps does not have the need or demand for those beds to one that does. Despite these occasional relocations, the provisions in our COMAR regulations allowing facilities to temporarily delicense beds has facilitated a gradual shrinking of the supply of nursing home beds in those jurisdictions that have surpluses. In terms of impact on other providers, that is likely to be minimal. 30 beds represents less than 1% of the licensed bed capacity operating in the jurisdiction. In terms of viability and financial feasibility, the facility has operated with a positive bottom line, and its projections show that to continue during the project, although during the implementation of the project there will be a decrease in margin, but still a positive bottom line. The applicant submitted a letter of interest from their current lender, PNC, expressing interest in working with Future Care to provide the project financing. In terms of compliance with conditions of previous certificates of need, looking at Future Care's track record there, a prior CON that Future Care had for a project in St. Mary's County, which was approved in 2008, was relinquished in 2012, essentially due to a delay caused by an appeal of MHCC's approval by other St. Mary's facilities, combined with, as time went by, the Great Recession, as well as Future Care's development within other regions in the state, which made development in St. Mary's County geographically, in terms of managing their assets less attractive. As well, Future Care received approval for a nursing home in Prince George's County in 2014, which is currently under construction. Some of the commissioners may recall that they did come back before the commission asking for a modification for a relatively significant cost increase. They've also been granted several extensions to performance requirements. That is not an uncommon occurrence with nursing home projects. So although these might seem to be bumps in the road, they do not constitute a failure to comply with the terms and conditions of a prior certificate of need. So wrapping up, staff finds that the proposed project is in compliance with the applicable criteria and standards and recommends approval with the 2 standard conditions related to signing an MOU with Medicaid, agreeing to maintain and then subsequently maintaining at least the minimum proportion of Medicaid patient days required by the nursing home standard. Present, representing the applicant today is the Vice President of Operations for Future Care, Les Goldschmidt. Fran Anderson, who is their project construction consultant. Andy Thalberg, the CON consultant, as well as their counsel, Howard Solins and Jack Eller.
Okay, thank you very much. Some familiar faces, I noticed. Any questions at all for Kevin? Yes, Fran.
Thank you, Chair. Thank you, Kevin, as always, for your summary. This is a situation wherein the nursing home is purchasing temporarily delicensed beds. And so, as you said, there's no net change in the inventory being the beds that have been available, although for some period of time, MedStar took them, or Good Samaritan took them offline, so they were not actually staffed. They weren't temporarily licensed, right? So do you know about how long that those beds lay fallow before this arrangement?
When beds are temporarily delicensed, the facility essentially has 12 months to inform us of their plans.
So it's time limited, right?
Yes.
So if I'm understanding the capital costs correctly on page 18, the cost of buying those 30 beds, which is a paper transaction, was booked at $285,000, which is $9,500 a bed. So what the commission here seems to do when we issue a CON is we do a lot of things, but we have just conveyed to the holder of that CON an asset that then can be sold under lots of conditions, and I guess can be sold at a rate that is privately negotiated. So in other words, downstream from MedStar at some point getting approval, getting a CON for some of those beds, they've now delicensed the beds and sold those beds, and that the cost of acquiring those beds is now built into this project. Did I get that right?
You did get that right. I
want to bring that to everyone's attention.
I do want to point out that they can only do that with beds that they have been operating. You cannot get a CON and then sell the beds before you implement the.
So you need to go to a sort of a step progression. But nevertheless, I guess, and thank you for articulating the cost, the upfront cost of consultants and legal advice in terms of the regulation of this transaction, but it's actually more than what you reported, because embedded in the transaction is the cost of acquiring the license, and I use that in a general term, that's been issued by this commission in the past, right? I mean, there's the cost in there that is not attributable to any value other than a piece of paper held at this point by Good Samaritan that is being transferred to Future Care, correct?
Yes, that's correct.
I just wanted to bring that to everyone's attention. Thank you, Kevin.
Thank you, Commissioner Phil. Very good. Any further questions?
Just one question. I know you don't have this, I'm betting you don't, but of the beds in Baltimore City, can you give us an estimate of what percentage of those beds are in facilities 2-star facilities and below, which would be
2-star and below?
Yeah.
I couldn't do that, Ben, without doing the research.
I mean, I think we consider all beds equal when we do some of these calculations, but some of these beds, we might not necessarily want to put our friends and relatives in.
Okay. Any further questions at all? Okay. Do I have a motion to approve Future Care Homewood's certificate of need? Second. Okay. Any further discussion? Okay. All in favor, say aye. Aye. Any opposed? Okay. Very good. Thank you, Kevin. Mr. Goldsmith, you have your certificate of need. Thank you, Mr. Sullivan. Thank you very much. Okay. Next agenda item is a change in the approved certificate of need. It's a relocation of Washington Adventist Hospital and the establishment of a special hospital, a psychiatric facility. Washington Adventist Hospital applied for a modification to its previously approved certificate of need that was issued back in December of 2015. Mr. McDonald will present the staff recommendation. Kevin?
Okay, thank you. The certificate of need, again, issued in December of 2015 to Adventist Healthcare to relocate Washington Adventist Hospital. The project cost was estimated at $336 million. Construction is in progress. The budget is, aside from this requested modification, the applicant has submitted quarterly reports that we're still on track from that cost perspective, and construction is expected to be completed by July of 2019. In that original project proposal, there was a central utility plant that would supply power to the facility that was to be built by a third-party developer. That original plan also included a surface parking lot as part of an interim parking solution for the hospital, with the recognition that in its master plan later on, as the campus developed, a parking garage would likely be in the future. The proposed changes in the project, I point those conditions out because of the proposed changes, is to build and operate the central utility plant themselves instead of having a third-party provider do it, at an added cost of about $39.3 million. And also to add the parking garage to the project, essentially advancing that in their master plan. It's anticipated now that with a medical office building slated to open around the same time as the hospital, that there will be parking issues, and the applicant would like to advance that part of their master plan and add it to this certificate of need. There have been several changes in the landscape since the CON was approved. First of all, Washington Adventist Hospital and Adventist Healthcare have exceeded projected financial performance by a pretty healthy margin. Also, that third-party central utility plant has turned out to be not the most cost economical solution for the applicant. In fact, through the bidding process, they've discovered that the actual first-year cost for these utilities will be more than twice what was originally estimated. And that's driven primarily by a much higher than projected cost of constructing the CUP, which then has to be passed on by the firm that would own it. So in summation on that, the applicant has said that it will be cheaper to build and operate it themselves to the tune of a $37 million savings in operating costs over 25 years. So the combination of Adventist's improved financial picture, the economics of the central utility plant, and the desire to accelerate the master plan for campus parking has led to this modification request to add those two elements to the project at an additional cost of about $64 million. I will point out that the applicant is claiming an ability to add these two plan components without a boost to its GBR to cover the additional project costs. The way our regulations treat a modification request is that an applicant needs to come before the commission with that request if there are one of several conditions in place. One is a significant change in the physical plant design. Another is capital cost increases that exceed the approved capital cost plus the allowed inflation factor. If operating expenses or revenue increases exceed by 10% what was projected in the application, changing the financing mechanisms, or changing the location of the project. Several of those triggers are tripped in this situation. The regulations also identify certain impermissible modifications, and none of those fit this situation. There's no change in the fundamental nature of the project. There's no increases in the bed capacity or medical service provision categories, and no change that would require an extension of time to meet the applicable performance requirements. The available actions to the committee is to approve the changes and incorporate them into a modified CON, approve the changes in part or with conditions, to not approve it, or to find that the proposed changes are of sufficient scope to warrant a complete new CON review in accordance with that process. Staff does not believe that the requested modifications would have an effect on the findings made by the Commission in the original deliberation. Looking at need, there's no changes in the nature, location, or capacity of services offered in the project. So there would be no, I would not expect any change in the need findings that the Commission earlier made. In terms of viability and feasibility, although the increase in project cost and the impact on the hospital's operating income is significant, the project still projects to be financially feasible with much smaller margins, but still a positive margin. WA is not seeking any additional extraordinary adjustment to future global budget revenues as a result of this additional project cost. In terms of cost effectiveness and of alternatives, when the original plan was put forward, Adventist needed to reduce the upfront capital cost of modernizing the hospital, and the central utility plant by a third-party provider appeared to be a creative way to reduce its capital costs. However, that has been determined not to be the most cost-effective alternative, and in fact, they would project to save $37 million over 25 years by building and operating it themselves. With that and the improved financial health of the hospital and Adventist Healthcare, the change in plan appears reasonable. In terms of impact on other providers and the healthcare system, there would be no change since the project is not really changing in its essence. There would be no change. There'd be no change in the impact to other providers, and because there's no change in the GBR requested, no impact on the cost of services. There is a supplement to the staff report that is at your place that I'll just explain briefly. The initial modification submitted to us and our analysis of it focused on the finances of the obligated group. When I realized that the obligated group is a subset of the entire corporation, we asked to look at that, and there is obviously different numbers there. Still, though, both ways of looking at this show a significantly improved financial picture for the applicant and doesn't really change the assessment that was originally made in terms of its viability and feasibility. Again, we have a contingent here to represent the hospital and the health system. Eric Wangsness, the president of Washington Adventist Hospital. James Lee, the executive vice president and CFO for Adventist Healthcare. Maureen Diamond, vice president of financial operations for Adventist Health. Jeff Morgan, vice president project executive for the hospital. Rob Jepson, vice president for business development for the hospital. Sasha Chen, vice president and CFO for the hospital. And Howard Solins, their attorney.
Okay. Welcome all. Thank you for being here. Commissioners, are there any questions for Mr. McDonald? Anybody? Questions for Mr. McDonald? None. Well, let me just make a comment. I think, thank you very much for your work on this, Kevin. I think the key point here is that this institution is spending its own funds. It's doing what is reasonable. It's not creating any problem for the state of Maryland. Their financial performance is really kind of stunning. I looked at the data, and for 2016, they were projected to have a revenue of $202,000. The actual revenue is $325,000. Actually, it's $326,000. That's fine. That is an indication of a very successful institution. I think it's obviously important for this commission to always keep in mind that when we're dealing with any of these matters, we're dealing with people in the private sector who are spending their own money. There's no taxpayers' money involved in all of this. With that, I would like to entertain a motion to approve the certificate of need. Okay. We have, all right, fine. All right, very good. Okay, any discussion, any further discussion? All those in favor, say aye. The ayes have it. Anybody, I assume, right, the ayes have it. Howard? Could you come up, Howard, just so we can hear you clearly? Okay. Thank you very much. Thank you very much for coming. Okay. The next item is a very big one. We are going to repeal and replace COMAR 102411, the State Health Plan Facilities and Services, governing general surgical services. What we're dealing with here is the product of a lot of work over several months. Actually, we're going to have proposed permanent regulations. Eileen Fleck, who is the Chief of Acute Care Policy and Planning, is going to present the staff recommendations for the proposed permanent regulations to replace the existing general services chapter, general surgical services chapter. She's going to discuss the staff's analysis and recommendations regarding the comments that were received on the draft that was released for informal public comment back on July 20th. Ms. Fleck.
Good afternoon, Mr. Chair and Commissioners. I'd like to begin by providing a brief overview of key changes to the State Health Plan chapter. So under the current chapter, a certificate of need is required to establish an ambulatory surgical facility with 2 operating rooms or more, but with changes suggested by staff, there would be new opportunities to establish an ambulatory surgical facility through an exemption process. These new opportunities include the following. A hospital may relocate 2 operating rooms from the hospital to establish an ambulatory surgical facility with 2 operating rooms. A hospital converting to a freestanding medical facility may establish an ambulatory surgical facility with 2 operating rooms in conjunction with that. And an office of one or more healthcare practitioners or group practice may establish an ambulatory surgical facility with 2 operating rooms. Staff is recommending these new opportunities based on feedback we received from the Commission in April and informal comments that we received. In terms of that last opportunity for physicians to establish an ambulatory surgical facility, we think that probably ones that already own a POSC are most likely to take advantage of that. And so we did look at the ownership for those based on our survey results, and about 60% of the POSCs are solely owned by physicians. We don't anticipate a surge in requests for these exemptions. There are only a few projects that we had in fiscal year 2014 through fiscal year 2017 where it would have the project would have been affected by having this opportunity for an exemption. I think there were 2 total, and then there's just 1 so far in fiscal year 2018 where it might have made a difference in terms of having an exemption process and not going through CON. So the exemption process for establishing an ambulatory surgical facility with 2 operating rooms will be similar in some ways to the certificate of need review process, but there are some key differences. The general standards must be followed for both of them. Those general standards include information regarding charges, information regarding procedure volume, charity care policy, quality of care, and transfer agreements. One difference is that with an exemption process, is that unlike CON reviews, they're not interested parties who have automatic standing to appeal the Commission's decision on an exemption request. The exemption process is intended to be faster and more streamlined, which is reflected in the number of project review standards. There are about half as many project review standards for an exemption request compared to a CON review. So the standards that would need to be addressed in an exemption request include need, design requirements, location, efficiency, and construction costs. In terms of the informal comments in our analysis and recommendations, I'll go over that now. So on the chapter content and applicability, we received comments from the University of Maryland Medical System and Mercy Health Services. They commented that a health system should be permitted to establish a physician outpatient surgery center because the relevant statute refers only to hospitals. We had previously included healthcare systems as being someone that would not have an opportunity to establish a POSC. And so we did revise the language to be consistent with the statute. On the general standards and the project review standards for CON, the University of Maryland Medical System commented that the language in 0.05A and 0.05B contained redundant provisions with ones in 0.06 that applied to the exemptions from CON. And so we did revise the language in 0.05B to specify that the standards are not going to apply to exemption requests that are eligible under 0.06. And then we also decided to combine section 0.06B for general and project review standards so that it references the applicability of the general standards to exemption requests. In terms of the applicability for exemption requests, the Maryland Hospital Association expressed concern that the expansion of opportunities, which I initially described, would result in supply-induced demand and unchecked growth in the total cost of care. It also expressed concern that hospitals will be held accountable for the total cost of care, but others who are establishing these ambulatory surgical facilities will not be accountable. We're not recommending changes for several reasons. The Maryland Hospital Association did not present evidence that an increased supply of ambulatory surgical capacity will result in induced demand for surgery. We don't, as I mentioned before, anticipate a surge in the development of ambulatory surgical facilities based on trends in the development of POSCs and the requests for those. We also think that it's in the state's interest to encourage surgery in lower cost settings when patient safety is maintained, and that was something that some of the commissioners expressed at the April meeting. And then also, the regulations can be modified if the trends in the development of these ambulatory surgical facilities raises concerns in terms of induced demand based on the expansion of supply. It also came up, although I don't have it on the slide, that insurers are actually pushing for this too in terms of moving surgery out of the hospital to some extent. So it's certainly not something that is, driven solely by the
commission by any means. In terms of the applicability, again, and the general and project review standards, the University of Maryland suggested that greater flexibility in the location of an ambulatory surgical facility is needed when a hospital is converting to a freestanding medical facility and establishing an ambulatory surgical facility in conjunction with that conversion. It specifically suggested that an ambulatory surgical facility be permitted within 5 miles of the freestanding medical facility or 5 miles of a parent hospital. We're not recommending changes in response to those comments because the flexibility that the University of Maryland Medical System is seeking substantially reduces the extent to which that ambulatory surgical facility is tied to the conversion to an FMF, which seems inconsistent with statutory requirements when someone is making that change. We would also note that the flexibility that the University of Maryland Hospital System is seeking is available if they were to relocate operating rooms before this conversion to establish an FMF. In terms of the location standard when someone is seeking an exemption from CO review, there was a question from the Maryland Hospital Association asking for clarification on whether or not the operating rooms that a hospital relocated to establish an ambulatory surgical facility had to be on the campus. In that draft that was posted for informal comment, we did not have any restrictions on it, but we did think about it further and decided that we should recommend that it be limited to the service area of the hospital, because that way the capacity will be used to serve the same patients in a lower cost setting, which is the goal, we think, to have care for the same patients but in a lower cost setting if possible. Another change that we decided would be, we would recommend is it's something that was not driven by comments, but just our own thinking about this further, which is we should be clear that co-location of an ambulatory surgical facility created through this exemption process should not be combined, in essence, with an existing ambulatory surgical facility or an existing POS with an operating room to then result in a facility that has 3 or more operating rooms, which should be subject to the CON regulations. On the efficiency standard, the University of Maryland Medical System commented that MHCC should not be mandating the adjustment of the global budget of a hospital because that's the Health Services Cost Review Commission's authority. And so they also expressed concern that the payment model could change and that would make the standard partially obsolete in terms of referencing global budgets, and maybe that won't be the terminology if it's used. So the University of Maryland Medical System suggested that the standard be revised to be more general with less specificity on the analysis required of an applicant, and it did provide specific changes to the wording in its comments. I think it might be helpful if I read for you the efficiency standard before going over our response to it. So the way it reads is under Part A, an applicant proposing to establish an ambulatory surgical facility through an exemption for certificate of need under this regulation shall demonstrate how its project will result in more efficient and effective delivery of surgical services by presenting an analysis that compares the level of efficiency and effectiveness of establishing a POSC instead of the proposed ASF. And then Part B is a hospital proposing to establish an ASF in conjunction with closure of 2 operating rooms shall demonstrate that the proposed ASF will result in an adjusted global budget that accounts for the lower surgical capacity of the hospital and is budget neutral or results in cost savings for Medicare and other payers with respect to the global budget of the hospital as determined by HSCRC. So that's the standard. And we're not recommending changes for it. Hopefully from that you could take away that it is HSCRC who's going to determine whether the hospital's budget is revenue neutral or resulting cost savings. The inclusion of that requirement in terms of comparing to establishing a POSC versus an ASF is something that stems from language in the statute. So we think it's very logical and consistent with that. And then lastly, the regulations may be updated if we need to address changes to the payment model or the terminology used by HSCRC. Okay. Next, we have the assumptions regarding operating room capacity. This is something that we talked about at the April Commission meeting. The University of Maryland Medical System commented that the language, some of the language in that standard is convoluted and it may not cover all situations where a different optimal capacity standard should apply. And the Maryland Hospital Association commented that it supports flexibility in determining the optimal capacity on a case-by-case basis. So the change that was made to the standard compared to the July document is adding another way for someone to demonstrate that a different optimal capacity standard should apply, and that actually pertains to looking at the costs and benefits for patients and the costs and benefits for surgeons. And so that's what was added to it. But we did, even if someone is going to take that route, we still wanted them to present the cost and utilization, the cost per case at various utilization levels. And so I can read the standard, or if you want to look at it, I think it's on, let's see, page 22 at the bottom. So we have like a standard optimal capacity, which is like a certain number of hours per day, number of weeks of the year, which is what we've had for a long time. It's long-standing. And then we talked about adding flexibility to it. We initially proposed something at the April meeting, and then we were told we should try to expand on it. So that's what we tried to do. And like I said, that standard is on like page 22, runs on to page 23. I could read part of it if anyone is interested, but I feel like I've tried to describe it as best I can.
Okay. Commissioner Pollack.
So I apologize for interrupting. I'm just trying to understand the flexibility issue and the applicability of it around the exemption. So if somebody applies for a 2 OR exemption and uses the flexibility argument around optimal capacity, says, let me give you an example. That we want 2 operating rooms. We've got volume for 1. And the justification is that we initially intend to run it 3 days a week because it's easier for us to operate staff that way. Surgeons can operate in 2 rooms at a time, can move back and forth between 2 rooms quickly. And for us, from whoever's applying for it, from their standpoint, their optimal utilization is that configuration. Is that consistent with, would we have the flexibility in that model to approve that?
Well, I think what we want to see is we want to see how does that compare to operating at the standard we expect, right, in terms of the cost per case, potentially. And then, I mean, and if the argument is not based on the cost per case, like maybe it actually is lower operating 3 days a week, right, versus spreading it over 5 days and having a shorter time each day or whatever the case may be. So the idea is for someone to present the analysis, to have some comparative information so that a judgment can be made in terms of does it makes sense. And it's not limited to a lower cost per case necessarily. We did want to have that information presented. I think that's a pretty straightforward way to do it. It seems like it should be reasonable, which is why we started with that. But we have expanded it to include the costs and benefits for surgeons and patients. So something would need to be said about that if the cost per case was going to be higher.
Yeah, cost per case, we're getting way down into the weeds here, and I apologize for that, but cost per case is such a nebulous concept, right? What kind of cost per case are we talking about? Because you can do any kind of model you want that shows that the cost per case is lower in an ambulatory surgery center than doing it in a rate-regulated environment. So your cost per case definitely it's about a third of a rate-regulated environment.
No, I mean it wouldn't be compared to a rate-regulated environment, but in terms of the utilization.
That's where we're trying to. That's my point. We're trying to move cases from a rate-regulated environment to a non-rate-regulated environment, and to decrease cost per case by doing that. And the ultimate argument here is that we want the flexibility in that unrate-regulated environment to be able to drive costs down by moving things out of a rate-regulated environment. That's the flexibility that we're hoping to see in this, to be able to people to come up with innovative models for driving cost of care lower than what we see in the rate-regulated environment, which is a wildly inappropriate way to do ambulatory surgery.
I mean, I can see that applies to certain situations. I think that, right, obviously a hospital, maybe they're relocating ORs, it's very clear, or maybe physicians are planning to move cases out and they say that. But I imagine there are other situations where it's not a matter of moving cases from a hospital location, but it's, taking cases from existing, maybe POSCs or another surgical facility, and they're then wanting to use this exemption process.
I get that. So but I think what you just said was consistent with what I was asking, which was that the model is one that allows you to be innovative in the structure of the ASC, POS, whatever, whoever's doing it, physician doing it, health system doing it, in a way that may be higher than the standard 1,600 cases a year, whatever, but or maybe more costly than that, but it's still cost effective in terms of what it's overall trying to accomplish.
Right.
That was convoluted. I apologize.
Mr. Director?
No, it's fine. I just,
So I
No,
think-
this is great. This is good conversation. Director?
So I think that the way you still have the baseline, which is the historical standard, we're not saying that we have to meet that baseline, but rather that when you provide an alternative, you still want to see how much different is that from the standard approach. If it's
I think there is an opportunity for judgment on this. Like, we haven't
have
said,
something to judge it by relative to a standard that we would be judging everyone else by, that doesn't mean that if you are higher, that you're going to be precluded, but it gives a basis for judging how much different is it. And I think that provides the flexibility that's appropriate with the caution that someone coming in with nothing relative to the common or the traditional means can essentially get an approval because you have an alternative method. So I think it provides some realism on alternative approaches that might not otherwise be available. And I think starting out, the applicant doing that as opposed to staff probably saves everyone time.
okay. And so, as I've written on the slide, so we're not recommending changes. We do think the standard is flexible and allows the commission to make decisions on a case-by-case basis. In terms of additional changes, we added a section .06C to address the transferability and procedural requirements for an exemption request that are consistent with those used for C1 projects. So these are things like, if you give an exemption to someone, they can't just transfer it to someone else. They need to the applicant needs to be the one that develops it. Things like telling us about first use with a certain number of days notice, letting us know if they've been licensed and inspected and that sort of thing. We do think that maybe those requirements that we're putting in here may be later moved to COMAR 102401 because that's where most of those requirements are. We tend to refer to them as the procedural regulations. I did want to mention that there were other comments by the Maryland Society of Anesthesiologists. They did comment in the first round of informal comments, public comments, and they're concerned with maintaining patient safety. They did not propose specific changes to the regulations, but we have said to them and responded previously to these similar comments by saying that we agree with that those concerns are valid, and we do want to track patient outcomes, and we will be doing more in terms of public reporting on the outpatient surgery data. And so that essentially concludes my presentation. I'd be happy to answer questions. I also did want to ask that the Commission adopt draft COMAR 102411, the General Surgical Services chapter of the State Health Plan, as proposed permanent regulations, and repeal the current COMAR 102411 on proposed COMAR 2411, contingent on proposed COMAR 102411 becoming effective.
Okay. Thank you very, very much.
You're welcome.
And a very, very fine job all the way through this difficult process.
Thank you.
And I think, I think I can speak for all the commissioners. We appreciate the hard work. Are there any questions? Yes, Dr. O'Connor.
This is, I guess, a legal technical question. Last year, Senate Bill 707 prohibited conversion of an acute care hospital in Kent County to a freestanding medical facility. Is that apropos to this COMAR? I mean, how does that tie in?
I think the statute stands. That would still be
This doesn't
the case.
trump
No,
that.
it does. No. You're welcome.
Commissioner Pollack.
So I just want to congratulate you on the revised version of this that I think is much, much better than what we had before. I know it's a lot of work. A lot of thought goes into how we got to where we are, but this is true. This is great. This is much better. Thank you. And I just wanted to make a motion to adopt staff recommendation.
That's fine. We have any more questions? We're still very democratic here. Okay.
Thank you. A comment, and I second the congratulations, Eileen, because it's been a long process. I'm super happy that Tressa introduced a new staff person to work on quality, on ambulatory quality, particularly with regard to this action and going forward as we are, yes, we're trying to drive down unnecessary costs. Part of doing that is moving procedures that heretofore had been inpatient into an outpatient setting. And so, you know, the little bit of concern there is, are we doing older, sicker patients that otherwise would have had procedures inpatient? Is it a riskier procedure that's happening? So the ability to really monitor any kinds of quality consequence of this action, I think, is super important to this commission. Certainly, OHCQ and other regulatory bodies will be looking at quality and licensing, but I think with this action, we take on ourselves a responsibility to make sure that we're not only driving down costs, but we're maintaining quality and safety. So thank you to Ben and to staff for recognizing that and stepping up on that side too.
Yes, Commissioner Flood.
One clarification, if one of these opens on the campus, the hospital campus, don't they still fall under the rate regulation?
I don't think that they necessarily would. I thought HSCRC makes the determination on that. I don't, and I think they would probably not be inclined to give, I mean, give rates if that's what they, if the goal is to lower the cost, we'd want to know about that. And so,
well, it was always my understanding if it was on the campus, it still falls under the purview of the rate regulation. But
I didn't think that was.
Yes.
So I think
Director.
that
HSCRC policy on this issue has meandered over the years, and I would say that given the prospective new model, that there's probably going to be a situation by situation assessment of that. Dr. Pollack has whispered in my ear that I think clearly when a OPD is attached to the hospital, that's a clear case. But if it's on the campus but not attached, I think that HSCRC has shown some flexibility over the years. And I would think that given the total cost of care metric, that they would like to have flexibility to allow lower cost surgery as appropriate and as attractive to consumers and workable for health systems and others who want to do this.
Any further questions? No further questions? Okay, the staff has made a request. The request is a motion to repeal and replace COMAR 102411, the state health plan for general surgical services with and with proposed permanent regulation. Do I have a motion to adopt? I have a second. Do I have a second? Second. Okay. Any further discussion? Okay. All those in favor of the motion, say aye. Any opposed? The ayes have it. Congratulations.
Thank you.
A lot of hard work went into it. We really appreciate it. Don't go anywhere, right?
Right. I think I stay here for the next one.
Yeah. You're very busy today. Ms. Fleck is going to ask the commission to approve the appointment of Dr. Jennifer Lawton to the Cardiac Services Advisory Committee. Eileen, the floor is yours.
Thank you. So probably most of you already know we have our Cardiac Services Advisory Committee. It's a standing committee to give us input on changes to the regulations. And we try to have representatives from a few organizations as well as hospitals and healthcare systems. So the representative for Johns Hopkins Healthcare System, Dr. John Conti, who had been one of our co-chairs, he has left Johns Hopkins, and so they needed to appoint a replacement. And so that replacement is going to be Dr. Jennifer Lawton, who is also the chief for cardiac surgery there and the director of the Cardiac Surgery Research Laboratory and the program director for the Cardiothoracic Fellowship Training Program. I haven't had the opportunity to meet her yet, but I'm sure she is very qualified, and so she's been nominated, and we would hope that you would accept her nomination to this group.
Okay. Any questions at all? Okay, the motion is to approve the appointment of Dr. Jennifer Lawton to the Cardiac Services Advisory Committee of this commission. Do I have a motion to accept the nomination? Yes. Okay, both commissioners. All those in favor of the appointment, say aye. Any opposed? Okay, Dr. Lawton is appointed.
Thank you.
Thank you. Okay. All right. The next item has to do with the health information exchanges. Privacy and security of protected health information is the topic. And the topic is draft regulations in this area. Angela Abbott, Chief of Health Information Exchange, will present the draft amendments to COMAR 102518, the portion of our regulations that deal with health information exchanges. This has to do with the privacy and security of protected health information. The proposed amendments aim to foster the exchange of sensitive health information to improve care delivery and to uphold current federal and state law regarding patient consent. Ms. Abbott, the floor is yours.
Thank you. So as you might recall, legislation passed in 2011 requires the Commission to adopt regulations for the privacy and security of PHI, shared through HIEs operating in Maryland. We are seeking Commissioner's approval to release draft amendments to these regulations for informal public comment. As the Chair mentioned, the amendments pertain to provisions for the exchange of sensitive health information. And through these amendments, we are aiming to foster and support the exchange of sensitive health information for improving care delivery and care coordination, and of course, uphold current federal and state laws where sensitive information requires more granular, explicit patient consent. A little bit of background information. The staff, as you might recall, works with our HIE Policy Board, a staff advisory group, to work to develop the policies that become sort of the framework for staff's development of regulations. The initial regulations, HIE regulations, went into effect March of 2014, and we've amended them twice since then, in June of 16 as well as June of 17. We currently have about 8 HIEs that are registered in the state of Maryland, including our statewide HIE, CRISP. So health information technology provides opportunities to increase healthcare quality, efficiency, and access to information. But along with the promise of these digital tools comes concerns about privacy, especially when we're thinking about sensitive health information. There are many ways that health IT can enhance privacy, but it also can magnify these risks associated with privacy breaches. When we're talking about sensitive health information, generally this information is considered to be information that carries with it unusual high risks in the event of disclosure, possibly of discrimination, social stigma, and physical harm. As defined, sensitive health information is a subset of PHI protected information that is specific federal state legal protections that requires patients additional or granular consent. Examples include genetic information, psychotherapy notes, certain communicable diseases, and in particular CFR Part 2, and we're talking about clinical records created or maintained by federally funded substance abuse treatment facilities. We want to make sure that this information is protected as it is exchanged through an HIE. So the need for the amendments, we want to make sure that patients with substance abuse disorders or other sensitive health information conditions are able to benefit from the sharing of electronic health information for treatment. We also, with the move of behavioral health into medical homes, a lot of these providers, both on the behavioral health side and the medical side, are increasingly requesting access to sensitive health information to provide information at the point of care delivery, but also in coordinated care of that patient. We also want to enable new care delivery models to be supported by information that can transform the delivery of care, making it safer, more efficient, and more effective. So under current HIE regulations, HIEs must only exchange sensitive health information electronically using secure messaging or email, or what we're calling point-to-point transmissions, through an HIE in accordance with state and federal laws. The proposed amendments continue to allow HIEs to do so through point-to-point transmissions, but also allow them to exchange sensitive information through other transmissions. If they do so, those transmissions must meet certain technical and process standards that are recognized by the industry to ensure that the patient's consent is captured in accordance with state and federal laws, and that consent choices are maintained by that technology and also accompany that piece of information as it moves through the HIE and is then disclosed to the provider. These proposed amendments also align with new federal regulations, particularly the update to CFR Part 2 and initiatives at the federal level to support the sharing of sensitive information, particularly the data segmentation technology supported by SAMHSA. So with the Commission's approval, we'll release the draft amendments for a 30-day informal comment period. The draft amendments could be revised based off of informal comments received. As we typically do, we plan on providing notice to a lot of our stakeholders that have been involved are impacted by this regulation. We're reaching out to our behavioral health stakeholders as well as others, and we expect to receive letters of support from this community. After the informal comment period, we potentially could come back to the Commission in November to propose.
Okay. Just a point of clarification, Angela. You're not asking us, obviously, to approve the draft.
Right.
This is just informational for the purpose of the Commission. Okay. Okay. I understand. Does anybody have any questions for Angela? Any questions at all? Okay. Okay, we'll be looking forward to them. Angela, you have a presentation for us on electronic health records. The Commission staff has done work in this area, and the information brief is on the physician adoption of electronic health records. There has been a widespread adoption of health electronic records and the meaningful use of those records as a component of healthcare reform, with the idea that this will improve quality of care, increase efficiency, and reduce healthcare costs. Ms. Avat will highlight the current trends and the staff initiatives to expand the adoption of the meaningful use of electronic health records. Angela, the floor is yours.
Great, thank you. So electronic health records are considered an essential tool in supporting practice transformation and value-based care delivery models. As you might recall, federal government implemented meaningful use incentives for the adoption of electronic health records through the HITECH Act in 2009. Since the implementation of the meaningful use incentives, as well as the state level incentives, approximately 28,000 payments have been made to eligible providers, totaling over 304 million meaningful use or federal incentive payments. On our state payer incentives, approximately 8,000 or 1,800 payments have been made, totaling $9.7 million. However, the impact of the financial meaningful use incentives on adoption has declined over the last 3 years. But EHR incentive adoption decisions are likely being driven by the influence or incentives available through value-based care delivery models. A little bit about the assessment. Annually, staff analyzes the Board of Physicians licensure renewal application for those physicians in the room. you have to renew your license every other year. And as part of renewal, there's several questions included within that application about practice size and location, specialty type, in addition to health IT questions. And we use that data to assess the adoption of health IT throughout the state of Maryland, particularly for this brief. We highlighted office-based physicians that are actively practicing in Maryland from 2011 to 2016. The aim of this assessment is to build stakeholder awareness around those health IT adoption trends, as well as develop EHR programs to advance health IT. So since 2011, EHR adoption has grown steadily among office-based physicians, and Maryland continues to remain ahead of the nation. As mentioned, the steady growth initially was attributed to incentives made under the Medicare and Medicaid EHR incentive programs, but slow growth of the last few years suggests that adoption incentives are not entirely based on meaningful use incentives. In terms of adoption by primary care and non-primary care, what we found is that primary care providers have a higher adoption rate overall since 2011 than specialty providers or physicians. The early adoption of primary care physicians may have been attributed to a few initiatives among family practice medicine associations. Back in 2011, there was a large initiative among a collaborative of family medicine physicians to encourage EHR adoption. And this also might be due to business practices and technology available to primary care practices versus specialty. For primary care EHR vendors, there's a typical template and features available. But for specialty practices or EHRs, they must be specific to that particular specialist and weren't necessarily in abundance in 2011. One other thing to note, but we're seeing a little bit of a higher growth rate among specialist ambulatory physicians than primary care. In terms of the technology used, as you'd expect, the majority of office-based physicians are using computers to obtain information about treatment alternatives and potential drug interactions. And while only about 51% of office-based physicians communicate with about clinical issues with their patients by email, this particular use of technology is growing at a faster rate than other uses as patients become more comfortable with email and communicating with physicians in that manner. In terms of EHR adoption by practice ownership, what we also find is that office-based physicians in hospital-owned practices are more likely to adopt an EHR. And this is regardless of whether or not they're primary care or non-primary care physicians. This might likely be due to the resources and support available to hospital-owned practices to adopt an electronic health record. So in terms of regional adoption, what we find is that EHR adoption is highest in the Eastern Shore, although the denominator is smaller, but growing at a slower rate than the overall national or statewide annual growth rate. And the National Capital Region has the lowest EHR adoption, but is growing faster than the state rate. So what are we doing with this information? What are the next steps? While we think that not 100% of physicians will reach or adopt an EHR, and we suspect about 10% might not ever reach adoption due to plans for retirement, practice size, support is available. There's still that 20% that haven't adopted an EHR. We are working closely with our partners at the medical associations to do an environmental scan to understand a little bit more about the challenges and barriers of those practices or physicians that have not yet adopted. We hope to work with the associations to, again, understand the challenges and develop diffusion strategies to help with those practices.
Thank you very much, Angela. Any questions? No questions? Maureen Carr York, you're dying to ask a question.
Actually, I just want to comment that the presentation was excellent.
Okay.
Thank you.
And easy to understand. And that's been the case with all our presentations today, which is why I'm not peppering you with questions. Thank you very much.
No problem.
It's not always a good idea, however, to agree with the staff. You know, just remember that. Okay. All right. Angela, anything? No, you, yes. Okay. Dr. O'Connor, do you have a question? I think the last item was No, it was not. No, it's not yet part of the regulatory process. It will the next time around. Right, that's correct. Well, yeah, wording. But Angela, thank you very much.
Yep, absolutely.
It's been great work. Okay, thank you. Okay, Ben, would you like to share some of the upcoming initiatives for the October meeting?
So I think I've already talked about that at the start of the meeting. We'll have the press conference on our price transparency tool. That will begin at 11 o'clock. Obviously, all the commissioners that can make it are encouraged to do so. And then the regular meeting, much of it will be devoted to the rural health delivery recommendations. We'll also have a presentation from Teresa's team on the health plan quality reports that are released this year. They've been modified and made more efficient. So we'll be, you'll see a picture of that, and we'll probably expect at least one CON action. I'm hoping that given that we begin at 11 o'clock, that we'll keep the regular meeting somewhat shorter than usual. As for the meeting today, thank you, Commissioner. But we did have 2 months to prepare. So we'll do our best in the future to make presentations clear.
Thank you very much. Before we may have a motion to adjourn, I want to thank the staff and Teresa, Ben in particular, for entering into a very productive relationship with the Leapfrog Group on hospital quality evaluations. One of the initiatives that we've all had here, a priority certainly of a number of us on the commission, is to actually do what we can to improve the transparency, not only of price, which we're going to have that big conversation next month, but also the quality of medical services. Price without quality doesn't tell you very much at all. And so this is a very, very big step forward. And I frankly think that this gives us an opportunity to really do a great job in informing our fellow citizens about actually what's out there. As you all know from previous meetings, we've had reports on quality in Maryland that have been somewhat mixed, to put the fine point on it. Everybody assumes because it's the state of Maryland that we must be at the very top, of the union. Well, that's actually not the case in many areas. But some areas, of course, we are. But anyway, this is a great initiative, and Teresa, we're looking forward to your report next month. And with that, there's nobody else wants to exercise their First Amendment freedoms. I'll entertain a motion to adjourn. I have a motion. Second. All those in favor? Aye. Meeting is adjourned.